Well, thank you, Dr. Farmer, and I want to thank everyone for the opportunity to talk here. Before I start, I just want to share briefly how I got involved in all of this. As many of you know, I have been doing 3, sometimes 4 trips a year to go to various parts of the world, usually low-income places, and do cleft surgery mostly, but also quite a bit of burn reconstruction. And this is not something that I had planned for. This is something that I got roped into by a friend initially, and I figured it would be a one-time deal. And then once you get there and you meet these patients and you see the overwhelming need and the limitations that they have in access to care, you realize that, you know, given the choices of taking a vacation and sitting by the pool for a week or going there and trying to help, you know, 6 kids every day, the latter is usually the better choice. So that's how I got roped into it. And there's many different models of getting involved or providing care in global surgery settings, and today I'd like to briefly discuss a few of these. I don't really have any disclosures other than the fact that I have been asked to give this lecture once before, and I did so at the meeting of the American Society of Maxillofacial Surgeons. So this is the second time that I'm giving this lecture with some changes for here. Again, I'm Pirko Maguina. I think everyone knows me by now. I'd like to start by looking at who is providing global surgery services. Everyone, of course, knows that the plastic surgeons are doing it. Everyone has seen the glossy ads on the magazines asking for money for cleft lip and palate surgeries. But the reality is that there are many other specialties that are doing global surgery. And a recent review of The Lancet took a look at 139 low and middle income countries and realized that the majority of the groups that are out there providing services are actually general surgeons. 38% of all the patients, of all the groups that were providing services were general surgery groups. Ophthalmology has a really strong representation with 28%, and then cleft lip and palate has about 22% of the groups that are out there providing services. Now that seems a little bit unusual even to me, because if you look at cleft surgery in any regular hospital around here, cleft surgeries represent far less than 1% of all surgeries that we perform here at UC Davis Medical Center and at any hospital in the United States. But it represents over 20% of all the global surgery services provided. Well, that really begs the question, why so much cleft lip and palate surgery? Well, there's a problem. Cleft lip and cleft palate continues to be a stark example of disease, of something that has not been covered, where there isn't enough access to services. And there's a backlog of about 4 million patients out there worldwide who haven't had any surgeries done. And this backlog is actually growing. If you add up all the number of surgeons and all the number of operations done every year and compare that to the number of children that are being born, whether cleft lip and palate out there, we're actually losing the battle. We're not making much progress at all. And every time we go out there, we continue to see many, many kids that have not had any services done. Global surgery, global cleft surgery has turned into the poster child for global surgery. And that's mostly because, like you can see on this patient of mine here, there is a really high visual impact while you're having really low resource utilization. I mean, what did I need to perform this operation? A small kit, I call it the Maguina tray. It has 11 instruments in it, a little bit of local, and well, we gave him general anesthesia, but this can also be done under local anesthesia, at least for the lip portion. So the cost is really low, the visual impact is really high, and if you measure it in a way that donors can understand, what you have is a really cost per averted disability adjusted life year, which is the lingo that donors are going to speak. Basically, it is similar to a vaccination in cost, but much more visual impact. So it's a really high winning combination for fundraising. As a result, 1 of every $4 of global surgery out there are going to cleft lip and palate surgeries. 25% of all the funding that is available. And another review of The Lancet reviewed 160 organizations working in 15 different specialties and realized that of all the money, again, a quarter was going to cleft lip and palate, but where is the money coming from? The majority is coming from donations in the United States. The US is incredibly generous. There is no other country in the world where people are so giving-minded, and we give 80% of all the money that's going out there for global surgery efforts, followed by the UK, surprisingly, Canada, Australia, and New Zealand. And when you start traveling, you do see that the majority of groups out there are either manned by people from the US or financed by people from the US, although you also run into some of the other groups. The cleft lip and palate, therefore, is going to be the example that I'm going to center this discussion around. There are currently, well, at the time in 2015, when this review was written, there were 313 organizations out there providing services for cleft lip and palate surgery. And there are multiple models in which these organizations are working. And there's a confusion sometimes about how to organize and describe these. The majority of them are still mission trips, meaning these short-term surgical missions. But there are more and more, and we'll discuss them during this presentation, long-term partnerships and other models that are coming along that are hopefully going to help solve the problem in a much more effective fashion. So, looking at the lovely hairdo of my friend here in Mali, I figured this would be a good example to go over the different models of global surgical care that we have available. There is a vertical model, there is a horizontal model, and then oblique or diagonal models, and we're going to go and discuss these briefly. Let's start with the vertical model, which is what we've done the most, which is what I have done the most. The vertical model of care is the parachute model. You come in and bring a big team, you bring their skills, their equipment, their supplies, you operate as much as you can, and then you leave. It's commonly used in rural, poor areas, and you can see our team here in Vietnam waiting for the bus. And it is the traditional mission trip. It is life-changing for a few patients, but it doesn't build any capacity locally. And it is therefore criticized as medical tourism. And at the end of this lecture, I'm going to show you how much fun medical tourism can be. There are plenty of criticisms to the vertical model. There are many trips that are irresponsibly implemented. I have personally, unfortunately, been part of some of those trips, and I have seen where the quality of care was being jeopardized by some less than optimal decision making. I've even seen how safety of patients was being jeopardized, and I've seen some really bad outcomes. What you oftentimes see, and I am guilty as charged, is that the providers oftentimes find themselves in situations where they're providing care that they aren't really providing at home. Here you can see me being an anesthesiologist after a 20-minute crash course when our anesthesiologist had to leave because Montezuma's Revenge would not let her continue the operation. And so she just had to tell me what to do to get this case out of the table. So I spent the last half hour of the case being an anesthesiologist, which is not really what I'm trained to do. I mean, it wasn't that difficult, but that's not the point. It does take a full 20 minutes of learning. Another criticism for the vertical model of care is that it can disrupt the local health system. We go to a small hospital, we rent the space, and nobody else gets to operate. And oftentimes the patients who normally would come there have to travel to a further away place. So that's not necessarily a great system. We're preventing the local providers from gaining expertise. You know, if I go there, and not just me, if all these teams come there and we're taking care of all these cleft lip and palate surgeries, well, it's unsurprising that 5 or 10 years later, the local surgeons don't have any experience doing this because you have to do these things to learn how to do them properly. And it's, of course, also questioned in regards of sustainability, its value, and its overall impact. Like I said in the beginning, we are losing the battle. We're not really making strides forward, and we're not decreasing the burden of disease that's out there. What's the defense for the vertical model? Well, the primary goal is direct care delivery. This kid here that I operated, I think in Vietnam, doesn't really care if the model is perfect or not. He just wants his cleft lip and palate fixed, and we did that for him. It has, therefore, some high value and sustained impact for the individual lives of these patients, and it does address the present needs. It is not a great long-term plan, but it fixes the problem right now. And here's the waiting room of that same trip. And you can see there is hundreds of patients. And this is the typical experience. We go somewhere, and if you have 150 to 200 kids lined up for the evaluation clinic, well, each of these kids shows up with a couple of adults, parents and grandparents, and next thing you know, you've got 600 people that are filling an auditorium, and you're trying to get through them to see everyone, and this is because there is a need that hasn't been met. These people are not there because they want to chit-chat with us. These people are there because they have no other option, and all these teenagers have not had any surgeries. And the other defense for the vertical model is that it may have some horizontal long-term impacts, because we do bring checklists, we do bring ways of performing surgery that focus on patient safety and are patient-centered, and then some of those models are starting to rub off, and we get to teach a little bit of our principles of keeping patients safe to the whole team that is there and hopefully impact their care over a long term. A couple of examples. Well, Shriners is a good example. We do have these outreach clinics in Mexico where we go there, we triage 50 to 80 kids on each one of these clinics, but then we schedule the patients for care in the US, and we don't really provide local care, although now there's some starting. And we do some teaching, but not really enough to establish local expertise over there. The added perk is that we have a lot of team building with margaritas on each one of these trips, and I don't think there is a single person working at Shriners Hospital that I haven't had a margarita or two with, which is great, you know. I wish I could say that about UC Davis, but another example are humanitarian crisis. Many of you guys know that we were involved with the Hermosillo nursery fire. 80 kids got burned, 40 kids died on the scene, and then we flew out there and did triage and transfer, and we brought all the kids here and then returned them over there. There was another less well-known incident in Mexico with the Puebla Virgin carriers. There is this Virgin in Puebla that has to be carried by everyone with a big basket of firecrackers in the back, which is not a great idea. And then one of the 18 carriers had the basket go up in flames, and all of the 18 ended up dying because all their baskets went up in flames, and 150 people around them got burned. But same thing, we went there, we did triage, we did transfer. Those patients ended up going to the Galveston Shrine, but that's beyond the point. There was no local capacity created. With that, I'm going to switch. There's many other examples for the vertical model, but I'm going to switch to the horizontal model because I don't want to bore you guys for the whole day. What's the horizontal model? The horizontal model is where you create capacity locally. You teach them how to fish. And there's many options. Here I am in Ecuador working with a resident. You can give lectures, there's fellowships, there's demonstration surgeries, there's local centers of care, and we're going to pay a lot of attention to that last section. Visiting professors is a great model. It's an effort to create capacity locally. It does require learners with advanced skills. I have been asked to go to Mali and teach people how to do cleft lip and palate surgery, and you get there and the local surgeons have very, very basic skills, and they just don't have any experience with any craniofacial surgery, and you cannot safely teach them how to do so. So you need someone who already is close to where they need to get, and you can only advance them one step, but you cannot go from 0 to 100 in a 2-week crash course. It also requires significant infrastructure. All of the surgeons in my team have been abroad to places where we wouldn't be able to perform the care that we perform here, because doing burn surgery requires a lot of infrastructure, not just surgeons, but ICU, nurses, therapists, and so on. And if you don't have any of those available, you cannot provide the same care there. And therefore, the effectiveness is somewhat questioned. It doesn't provide any care, and it certainly does not address the barriers to access to care. Another example of horizontal models, international fellows. Here's Fernando, one of our fellows. It was extremely effective, but extremely expensive. If you bring someone from abroad to learn here with us for a whole year and really bring them up to the level where you'd like them to be, you have to have $100,000 plus to pay for all the costs involved with that. And then they return to their country of origin. Another one of our fellows is now the chief of burn surgery in Mexico City, Mario. And so it does certainly create capacity that is very well trained, but it still does not address the issue of barriers of access to care, because these surgeons, once they go back to their local communities, cannot necessarily provide free care for anyone because we're not really paying for that. And that brings up the new model. The horizontal model of care is now revolutionized by the local care centers. And the big bright icon out there is the center in Guwahati. I might be mispronouncing that. What Operation Smile did is they partnered up with the local government in Assam, with the Tata Motor Company and a couple of other private investors, and they created this state-of-the-art facility that has several tables in one huge room, and they are doing hundreds of operations. And what they did is they brought in surgeons from the United States to teach the local surgeons, and now all the care is being provided by the local surgeons. And it's really an amazing facility where they have more volume than anyone I've ever seen. They've done, I think, in the region of 8,000 cases by now, all of cleft lip and palate surgery in one center, where their outcomes are driven by volume and they have really good experience. And so this does meet the surgical needs in a durable, long-term fashion. They are teaching them how to do it, and they're financing the cost, and therefore they are solving the problem of access of care, which is something that none of the other models really are doing. They do have huge problems of their own. There's been all sorts of problems regarding diversion of funding, things getting stolen, people not continuing there after a short while and going on to private practices. They've had huge problems of their own, but it is, at least in theory, a model that should address the issue of training and access to care. Which model is better, the vertical model or the horizontal model? Well, the cleft lip and palate missions are going to affect the health system in indirect ways. The traditional thinking is that you can either only be vertical or only be horizontal, but the truth is that more and more people are starting to recognize that all programs have a combination of both factors. When we go repeatedly to one place and perform surgeries, we're also teaching a little bit. We're not just performing the surgeries. And the other way around is true as well. And I don't really know which system is better, but what this combination and ill definition of systems has created is what we're going to describe as the oblique model in just a moment. Before we go there, let's talk about cost effectiveness, because ultimately this is what's going to drive things. Money talks, and this is what's going to point us into the right direction. If you compare the cost effectiveness of these local surgery centers to the cost effectiveness of the mission trips, it is cheaper to provide the care with local surgery centers. And if you look at the incremental cost effectiveness ratio, which is the delta in cost over the delta in effectiveness, basically how much it costs to create an additional unit of effectiveness, which is measured in disability adjusted life years, you're going to have a cost delta of about almost $500. It's almost $500 more expensive to do mission trips per daily averted than to do it with a local center. How is the money spent? Well, if you have a mission trip, you're spending a third of it locally, and the other 2/3 you're spending in air travel and accommodations. If you have a local center, you're spending 95% of the money locally, most of it in salaries and a little bit of it in infrastructure. And remember, donors love to give money for infrastructure, brick and mortar. Now you got to have your name on some place, even if it is in India, your name is somewhere, rather than paying for plane tickets. So there is definitely a transition and increasing popularity for these long-term centers, and they are popping up everywhere, not just in India anymore, because they're perceived as being a more sustainable, durable model. This cleft care center model, therefore, appears to be growing. When I reviewed this, but I didn't review this, when I read this article of 2015, they had found 37 centers at the time, and I'm sure there are more now. We Enshriners also have a bit of this going on. We now are starting to provide more care in Tijuana, and Tijuana has a collaboration with Shriners, and Shriners is paying for local surgeons to provide cleft care there, and they're doing a really nice job. So local experts are being hired, and the cost of the care is being underwritten by Shriners Hospitals for Children. It does recognize that the barriers to care are often money and not just the lack of local experts. Many of these poor places that I've been to have local experts that are just as good as I am. Or better, and they have taught me things, but they cannot provide free care because they don't have funding behind them to underwrite that. And so when we go there, what we are solving in some times is the lack of experts, but in many times it's just a problem of access of care. Last model, the oblique model, also known as the diagonal model. Here what you do is you provide care and you teach. So you hopefully are going to get the best of both models. A recurrent mission trip to the same site, hopefully, is one good way of doing that. You get to train the local residents and surgeons. And one example is Rostros Felices in Ecuador, and I've been to their site several times. This is a residency program for plastic surgery training that includes 4 to 6 trips a year, each trip 1 or 2 weeks long, with visiting surgeons from around the world. So they are actively recruiting and inviting plastic surgeons from around the world to perform the operations with their residents, with the expectations that they're going to create better training opportunities for the residents. Smile for Children is another oblique model. They are training Vietnamese surgeons and anesthesiologists during their mission trips, and then they pay for those surgeons to go to Korea. I've not been to Korea, but it sounds like it's worse off than Vietnam if they're doing this. But they are also providing the equipment and the supplies, and they found this model to be incredibly cost-effective because these Vietnamese surgeons and anesthesiologists have really low salaries. By hiring those surgeons and taking them to a place where there is a great need that has not been met, they can provide a lot of care for very little dollars, and their daily ended up costing $97. Research, which is the organization that I've done the most traveling with, Reconstructive Surgeons International, has an oblique-ish model as well. They do provide these mission trips in a vertical fashion, but they go to the same 17 countries year-round, year after year after year. And in each of these sites, they have 1 or 2 local surgeons that have to be trained by the visitors. And then while we are gone, those surgeons continue to get salary for continuing care year-round. So they get this recurrent exposure to international experts, but are also getting underwritten in their salaries so they can provide care and continuity of care for the patients that we have treated. The Guyawati Assam Cleft Center that I mentioned earlier started as a diagonal system as well. They were going back to the same site over and over, and then they established a long-term relationship. And with that, I'm going to wrap up the models of care. But before I leave the podium, like I announced earlier, I'd like to share with you guys a little bit of the joys of medical tourism. Because every time I go on one of these 1 or 2 week trips, which is done during my vacation time, I come back and people ask me, so how was your vacation? And I just want to answer that question, how my vacation was. So this is how my vacation usually looks. And it starts with transportation, with the cheapest and longest flights you could possibly find, because the donors are not going to pay for first class tickets. So it's Econolite or my favorite Fiesta class. If you guys have been to the Philippines, they have in Filipino Airlines first class, business class, economy class, Fiesta class. And Fiesta is no party. You know, I've never been so cramped so tightly into a seat like in Fiesta class. You get there and you have quite colorful land transportation, usually with tuk-tuks or some buses that are falling apart. The accommodations, the Shilton is not the Hilton. There's a shh for a reason there. They tend to be clean, but they're really not comfy. They're very inexpensive, and they oftentimes are very, very loud. All of them have karaoke bars for some reason. There's always a wedding or some big party happening when we get there, and there's always a couple of things that disappear here or there, so there's some risk for theft with these places. The locations are also not really what I would call a vacation destination. They tend to be really poor areas, oftentimes slum areas. We don't get invited to like Paris. I mean, if anyone is organizing a mission trip to Paris, count me in. But short of that, we end up to all these places. And you can see by these pictures that this is not what I would consider a vacation destination. The leisure time that we get to enjoy there, typically it's 12-hour days, sometimes it's more. We do 5 or 6 cases per surgeon per day, and there's not a whole lot of time for sightseeing, although on occasion I've stayed for an extra day or two to get to look around a little bit. The food, that's Vietnam, where they were trying to serve us grilled dogs, which I couldn't get myself to eat on the upper picture. The lower picture, I love guinea pigs. I mean, I'm half Peruvian, you know, and but the bottom line is the food can be challenging, and it's always high carb, high sodium, low protein, and the protein is colorful. And people get sick during this trip, so you've got to pack snacks. You cannot eat any of the salads, nothing that has mayo, because otherwise you're going to be like my anesthesiologist, and then I'm the anesthesiologist. But then in addition to that, there are some real problems. And this is really the sticking point, the real issue that I have learned to live with and don't know quite what to do about. There are some cowboy visiting surgeons. I have unfortunately seen a patient die on the table, not on my table, but in the room next door by a cowboy-esque surgeon who was performing some gigantic operation in a very unsafe place. Oftentimes I've seen quite poor care by local providers who suddenly find themselves encouraged to also perform these operations that they've now seen once, and then on the next day they are doing some of these things and with dismal outcomes. I have seen that there's a lot of politics involved in many of these trips, and you always wonder if you want to speak up or get invited back. You know, on one hand, you're providing the better care, at least you think so, and on the other hand, you want to not fight with everyone when you see things not being 100% kosher. And there are some ethical dilemmas. Are compromises acceptable? Is below the standard of care better than no care? I've been unaware of cultural differences. Of course, we don't do this at UC Davis, but in other institutions where I have worked, we would often poke fun at the residents when we're in the operating room. And I've done the same thing in Ecuador at that Rostros Felices thing, and I've offended them, and the residents suddenly ran out crying. I'm like, what did I do, you know? So you have to be sensitive to the cultural differences. There are difficult situations. You go there to do cleft lip and palate surgeries, and next thing you know, the head nurse shows up because she wants a breast reduction, and everyone is telling you that you have to perform that. She's a VIP surgeon. There are some unethical behaviors that you encounter. Many patients have been charged by promoters, and this is something that is always hushed, but eventually you find out what's going on and how one patient got to be on the schedule over another patient. The local staff is suddenly displaced. They didn't really sign up for this crap. I mean, their administrator told them that you're going to show up, and all of a sudden they don't even know what to do, you know? And there's different reactions. Most of them try to make the best out of it. Some of them resent the whole thing, you know, particularly some of the other surgeons that would be billing and performing surgeries, and all of a sudden are blocked from accessing the operating room. And then there's other outliers that are a little bit too friendly. So it's something that you have to navigate with care. The hospitals, there's a huge range from really basic to downright dangerous and unsanitary. We don't get invited to high-end hospitals, and they've got the weirdest rules. In Vietnam, you walk into the operating room and they've got this dozens of really dirty shoes, and you have to take off your shoes and wear one of theirs, which makes no sense to me. In Ecuador, they have these gowns hanging that are nasty, and you have to put them on before entering the patients' rooms. So it's sometimes hard to understand and certainly colorful. And then there's trip politics. Numbers drive donors. And I've been on trips where suddenly they'll show up with a patient that really didn't need this procedure. They bring this kid in and say, you got to cut out these 2 scars. I'm like, what for? I'm not doing that. But they are trying to maximize the numbers and squeeze in yet another patient, whatever they can find. They lax up the indications, and oftentimes there is less safety standards. There are perks. There are definitely perks. Friends and colleagues ask you to join them. Everyone is like-minded. That's Paul next to me, who's one of my best friends now, and I've been on like 8 trips with him. You get to meet new friends and strengthen existing friendships. There's academic opportunities. You are working with local surgeons and teaching them. And in teaching, you actually learn more many times than in actually just doing it. And if we're going to be completely honest, we, the volunteers, get to increase our own experience by volume. I have done probably in the neighborhood of 400 cleft surgeries. I wouldn't have done 400 cleft surgeries if I hadn't gone abroad, and I feel like pretty confident that I am an expert-ish on cleft surgery, but I wouldn't be one if I hadn't done 30 trips, So you get to do hundreds of clefts abroad. But the biggest perk, and the reason why we're all doing this over and over again, are the patients. Because if you meet a kid like this who's 10 years old and is being shunned from school and fix the lip in an hour, and then the patient comes back, and this actually has happened to me, and tells you, they're going to let me go to school now because now I'm normal. Well, then you cannot help but go back, despite all the problems, on the next time that they call you and ask if you're going to come along. And we see lots of clefts, and sometimes some really challenging facial clefts or nose clefts, or more clefts here, or hemangiomas, or minor things like syndactyly, or loads and loads of burns. Burns is a problem of poverty, and all the developing countries have tons of unaddressed needs there. More burns and more burns and more burns. And you can see that the patients are the real reason why those of us who are involved in this get involved in this and keep on doing it. Conclusion slides. There's many models to address the global surgical needs. There certainly is a lot of overlap between these models. The vertical model probably has a horizontal effect, and the local specialty centers may be increasing, and there might be some other models. This is the Orbitz plane. They actually fly a whole operating room there, which I'm so jealous about. And final thoughts. Mission trips are not a vacation, but they're also not the perfect solution for the problem of access to quality of care. And the mission trip's main mission should really be to eradicate the need for them. And with that, I want to thank you all.
So, thank you, Pirko, for your always inspirational as well as entertaining approach to almost any topic. It's really great. And I think you did a really lovely job of describing the sort of breadth of exposure to these kinds of things. And, in addition to our residents, I would be remiss in saying that, I think everyone knows that Dr. Young, won the American College of Surgeons Volunteerism Award last year for his approach at really looking at, developing those longitudinal, vertical approaches to mission trips that is really a model for this kind of care. So we have some time. I'd love to open it up for discussion. I do want to say that it was hard listening to your talk not to think about the parallels of need in this country. And as we look to changing the Affordable Care Act, and we all know at Shriners we see so many kids who don't have access to care in our regular health system, which I didn't know until I started working there. It's just really astounding. I thought we need Tata to fund one of those mission trips here in Sacramento and open one of those centers, and we could line up a lot of kids as well. So it's not just an issue of developing countries. It's a healthcare delivery issue everywhere, but I think you really defined it well. So, questions?
Tina.
And comments?
So, Pirko, if someone in this audience is thinking of doing local surgery or going to one of these volunteer trips, what would you ask them to look for so that they can get the best experience and avoid the traps that you clearly know?
Well, I don't know a way of avoiding the traps, but the best starting point is to go to their college websites. The American College of Surgeons, the American Society of Plastic Surgery, pretty much every major surgical organization has links on their websites for volunteerism. And they do encourage people to contact them, and then they can match you up with people in your area that are already doing the work. I would not encourage anyone to try to invent the wheel by themselves and start their own mission trip from scratch. I think it is much easier to go with a group that has done this a couple of times and has already figured out some of the problems.
So just see a show of hands of how many people have been involved in some international surgical experience. So that is well more than half of the people in this room. So, you know, this is not a hypothetical conversation that we're having. This is great. Questions? Dr. Hundle, I thought you had your hand up. No? Guy, do you want to take a minute and tell people about your experience at the WHO? Put you on the spot.
Sure. So I went to Geneva for 3 months. I worked for it was actually ended up being a joint project with the World Health Organization and the International Committee of the Red Cross. So the guys that, you know, enforce, for lack of a better word, the Geneva Conventions, and really are specialists in complex surgery. And what they were working on was trying to put together a set of guidelines for management of limb injuries in disaster and conflict, so that all the Red Cross surgeons who were going out and their in-country providers were working off of a set of guidelines that were basically how to do surgery, how to manage these injuries safely, and how to do that within the purview of what the WHO has started as basically a registration system for emergency medical teams. So in disaster response, it used to be kind of a free-for-all. We saw how poorly that worked during Haiti, and the WHO has basically started registering teams and fitting them into 3 levels of care, and really defining the scope of care and the amount of training you need to be a part of this. And that system is up and going. So what we wanted to do was create a set of guidelines that took what is not great evidence line there is really sort of rigorously done expert consensus, create a set of guidelines in a form that's easy to use, easy to carry, and fit that into these scope of care registration frameworks that WHO started. So we turned out a book, which I'm happy to share with anyone. A digital copy and some hard copies left, as well as an open access website that has not only all the chapters of this text, but also narrated PowerPoints and videos, including Dr. Salcedo Galante's work on shunts for temporary vascular shunts for arterial injuries, and that pairs with the book and is open to anyone. So that was the work that I did, and then a little bit of work with the team that's planning the WHO's work around Mosul, setting up trauma teams around there.
So thank you. So I'm going to put another person on the spot who had sort of a different experience with a different kind of international experience, and that's you, Dr. Pevick. So why don't you talk a little bit about your trip to China?
Also, before that, maybe I won't talk about that, because
okay.
One thing I want to mention is, Pirko, you presented this as not really a vacation, but vacation, something that you clearly enjoy doing. And one thing that you kind of didn't speak of this, I spent a couple weeks in Landstuhl, Germany with the military hospital. They're taking care of wounded warriors.
Mm-hmm.
And one thing I found remarkable is the sense of mission. So you work at your regular job and people are complaining they want to go home, they don't do this, they don't want to do that. And it's not as much fun. Everybody there was about getting those service people better. And I suspect it's the same thing when you go on a mission like that. Everybody wants to be there, everybody's happy about what they're doing, everybody feels like they're doing something worthwhile. And I think that's extremely rewarding. I suspect that was a big part of why people sign up for this.
Well, I share with the students sometimes that plastic surgery is so much fun that we all like to do it on our vacation time.
There you go.
You know, I mean, how lucky is that? You know, you get to build something. It's like playing with Legos, except they bleed a little. You know.
But it's more fun when everybody is having fun. Everybody really wants to do it.
Yeah.
So there's a great message there, which is how do we make sure we all find the mission every day in what we do, and as leaders of our teams, bring that mission to the operating room environment, and what that might do to help improve how we all work together.
We should. It ought to be fun. This ought to be. We ought to have that sense of we're doing really important stuff. That's very valuable, and it ought to be fun to come to work. And we sometimes lose that.
Yeah. It is a privilege what we get to do.
Yeah.
But to answer what you said in China, I didn't do it. That was not a medical mission at all, because that's a very developed country, and I didn't actually do any procedure. I mean, scrubbed on some stuff. I actually do procedures, but the other point that Pirko brought up is you learn a tremendous amount from the local colleagues that you visit, and it's a great learning opportunity to realize there's a lot of different ways to do things. And if you go there first and you say, "Oh, that's terrible the way to do that," or "You can't do it like that," and you realize some of the stuff you think you absolutely have to have, and you absolutely have to do it this way, is not necessarily the case. You can provide pretty high standard of care with very different models than what we do here. You can put on dirty gowns. I put on those dirty shoes in the OR in China, and it doesn't seem to cause a problem.
Pretty interesting. I think we'd be remiss in this program also not to highlight the great amount of international medical care that's provided by our military colleagues through the work that they do, not only to the servicemen that they care for, but locals in their environment as well. I don't know if there's anything you want to talk about, Jacob, in terms of some of your experiences.
Well, I don't know that I have a whole lot to that. We do encounter care for local nationals and stepping lightly in the political situations that we find ourselves. I think Pirko's point about disrupting the local healthcare system is a really important one to remember, that there are local surgeons, there are local physicians that you're displacing when you come into a place, and having respect for the jobs that you have.
Nilas?
Yeah, I would, that was a great talk. I identified with a lot of your aspects of the talk, particularly the guinea pig. Well, I'm sure guinea pig is.
I don't know.
But I think the name of the game now that the funders have pretty much embraced this capacity building. I think that's where the funders are headed, and a lot of funders have supported a lot of different types of missions, but I think just like with Operation Smile now, they're focusing on capacity building. I think capacity building has a lot to do with engaging the local governments and embarrassing them, if you will, into providing the appropriate levels of care for their populations. And we have a team in Peru right now, and today, in fact, the American ambassador Peru is going to the hospital where our team is working in Lima, and there's going to be TV cameras from every news outlet, and that doesn't happen by accident. We actively pursued the staff people in the council's office to make sure that we could get the council, the ambassador there, and we have infiltrated the media outlets, and we have contacted them to make sure that when the team goes, that the whole population of the city knows that this is happening. And one of the first questions that the natives ask is, well, why can't we do this ourselves?
Mm-hmm.
Okay, so you really have to, if you're successful in putting that into the minds of the local population and making the local government aware of that big question, it goes a long way to capacity building, because then you will succeed in developing infrastructure over time, so that you don't go somewhere, do a good job, help a lot of people, leave, and everything falls apart.
Mm-hmm.
And I would just add that I think some of that kind of activism could be well utilized here in this country as well, and figuring out how to get those lessons that we're learning on developing things there to meet the needs of many people whose needs are not met here. So it's really a great lesson in many ways. Dr. Wong, Ranger.
I think that the medical missions are absolutely phenomenal, and as a participant on especially between 20 and 30 export a team over to the area. And then we do a bunch of cases and we leave. We'll go back next year or the following year or so forth. And that's not really sustainable. Even what Dr. Young was saying, when we bring light upon these needs to the government and to the Ministry of Health, they don't have the resources to necessarily divert from something to heart surgery or something to palate. So I've seen this as a sort of a somewhat unsustainable model in the sense that medicine is not separate from the overall well-being of the country. So the country has problems with transportation, the country has problems with education, the country has problems with medicine. And how do you elevate the medicine inconsistent with this sort of standard of living or the general well-being of the population? And I think that's what we have to think about. But it's absolutely worthwhile to go and make a difference. But I think we need to re-examine the model of how we export our medical records.
Well, I think the comment of just the concept of exporting our medical technology, and in fact, is this country's model the model that we in fact want to export? And I think as we see the extreme divides between rich and poor in this country and the service access availability between rich and poor in this country, we're not so different than many of these countries that we think we're helping by going to visit. So these are healthcare problems that are important to address everywhere we go. So thank you for bringing us a moment of mission back to the department, and I hope we can take the mission with us as we go forward and do all the things we do here every day.
Thank you.
Thank you.